Thank you for joining the National Headache Foundation's Psychiatric Co-Morbidity of Headache webinar. Today we are joined by Dr. Maurice Preter. Dr. Preter is one of a handful of duly board-certified specialists in both neurology and psychiatry worldwide, and he practices as a neurologist, a psychodynamic psychiatrist, and psychopharmacologist in New York City. In today's webinar, Dr. Preter will focus on recent panic anxiety research and how findings from panic might be relevant to migraine sufferers. He is also discussing the epigenetics of early childhood adversity, PTSD and migraine, traumatic brain injury and migraine, and the effect of neuroscience, treatments, perspectives, and other topics. Dr. Preter, thank you for joining us.
Oh, it's a pleasure. Thank you very much for the kind introduction. We're going to start with a little bit of a slideshow. It's not going to be an academic lecture. I don't think that's what we want to do tonight, but we will basically touch upon some interesting topics related to psychiatry, neurology, headaches, and there will be questions, and there will be time for questions. Probably not enough, so we could certainly continue our discussion later through email and such. I'm going to start with my PowerPoint here, and I hope it's not too cryptic. Topic is comorbidity between headache, migraine, and whatever psychiatric disorders we'll talk about. I'm going to start somewhat atypically with book recommendations. And one of the best books I would like to recommend looks like it's pretty old, but it was written by Stanley Cobb, who was a giant of neuropsychiatry and the chair of the neurology department at Harvard in the 20th century, mid-20th century. And I'm just going to read this to you because this is sort of what I'm getting at tonight, and then we'll flip through some more slides. What we're really looking at here is the mind-body problem. And he says, he says certainly that there's no such problem. And then he continues, there are, of course, plenty of problems concerning the mind and the body and all intermediate levels of integration of the nervous system. He goes on by saying that the difference between psychology and physiology is merely one of complexity, which I think is relevant for tonight and for looking at these very similar disorders and trying to figure out how they relate. He says the simpler bodily processes are studied in physiological departments, and the more complex ones that entail the highest level of neural integration are studied in psychological departments. All right, the second book, you can find that book on Google, I believe. I'm not certain though. The second book that I highly recommend is by Siri Hustvedt, the author. Now, this is not about migraine headaches primarily, but it's about a brilliant author's, it's the wittiest account of a patient traveling the world of neurology and psychiatry trying to get some help. It's really interesting, and I would like to recommend it. We discussed the book when it came out 2 years ago or so, and if you're interested, you can listen to the discussion of that on my website and probably on Siri's website as well. This is a new book of a different approach. It's a multi-author book about the neuropsychiatry of headache that will be published in a few months from now. And I was honored to write the complementary alternative medicine approach chapter in that book. Although I'm not primarily a CAM practitioner, I certainly learned a lot during the process, and I'm very happy that the book is coming out soon, and it's really worth reading if you're interested in the subject. So that's what we're going to talk about. I'm going to show you a few numbers. I'm not going to go into any great detail because you can read those studies, and I don't think it adds to our argument tonight. But basically, we're looking at a great deal of so-called comorbidities relating to migraine or chronic headaches. We're not going to talk about stroke. There's, as some of you probably know, a genetic syndrome called CADASIL that comes with stroke, dementia, and lots of headaches. It's a very tragic, very rare disease. What we're going to talk about are those really non-genetic diseases that may, like everything else, have some sort of genetic predisposition but are mainly environmentally based. And those are anxiety disorders, depression, asthma, and many others that we'll touch upon briefly as we flip through the slides. What are the numbers? The numbers are quite astonishing. Depression is much more common in people with migraine, including bipolar depression and mania. So the risk ratios here are high, 4 to 5 times. including smoking, which is quite interesting. I've been interested in panic disorder for a long time, and clearly smoking is a risk factor for panic disorder as well. I'm not sure if there's a study that shows that smoking directly increases the risk of having migraines, but that would be an interesting thing to do. The highest risk of all these more or less well-defined disorders is panic disorder. The chances of having panic disorder is at least 6 times higher if you also have migraines. So this would be something to study very carefully, and some of that has been done. This is just the DSM definition of major depressive episode, not something we are all that concerned with tonight, but certainly something to keep in mind when we want to do research. A few studies of migraine and depression. Many of you will be familiar with the numbers. Again, the risk of developing depression after having been diagnosed with migraines is about 3 times the average population. And there are some new studies that have been added. They all pretty much give us the same result. Even more interesting, I believe, is the very high risk of having panic disorder when you have migraines, and the other way around. What's interesting here is that you can have panic disorder without being anxious, which is relevant to our argument and relevant when you try to figure out what's going on and why people with panic disorder also have a lot of migraines. And you can see here a very long list of not exactly psychiatric symptomatology going really all over bodily functions and organ systems, anywhere from the gut to the inner ear to peripheral neurological symptoms to what looks like a heart attack. I like the old literature, as you can already tell from my mentioning Stanley Cobb's book. This is even older. This is by Freud, before the turn of the 20th century. So all of this has been discussed and tried to figure out for a really long time. Okay, this is a very important study by Breslau, and it's important because it is a population-based study. It's not a study of, let's say, a neurology office or a clinic, which means we're looking at people who are not seeking help at that time. We're looking at basically regular people that are not currently suffering from several diseases. So the research quality is considered much higher. And what it shows is it goes both ways. You can start with migraines and develop panic disorder, and you can start with panic disorder and then develop migraines. The numbers are slightly different, but they point to a common origin of those two that needs to be explained. You can see that the risk for people with migraine with aura is a little higher, but all in all, the numbers are quite staggering. Again, we have 6 to 8 to 5 times the risk compared to people who don't have either one, panic disorder or headache. And it's not limited to migraine. So when I say headache, I use them interchangeably because it's, for our argument, it's not different between migraines, chronic daily headaches, cluster, and various other types. Okay, this is what I just already mentioned. The chances of migraine predicting panic disorder is higher than the other way around, but it's pretty impressive all in all. Nothing we haven't known already, because when you see a lot of patients or when you're a patient yourself, this is a very common observation and unfortunately causes a lot of therapeutic issues and causes a lot of suffering. Now, something else we need to talk about is psychological trauma. Not something that most neurologists are very familiar with, and nobody really likes to talk about psychological trauma, but I think it's very relevant to the argument. And what we can see here is that, no surprises, the effect of trauma in terms of developing PTSD is cumulative. The worse you get hit, or the more knocks, hard knocks you get, the more you suffer from PTSD. And there are various types of PTSD. It's not necessarily the DSM type, full-blown PTSD with flashbacks and nightmares and so on. Many people don't really have flashbacks, they're just very numb, or they develop chronic pain. This is basically more of the same with some numbers attached. Single events are not as traumatic on a population level. That's no comment on individual people compared to 2 or more events. And the risk of developing PTSD increase with the number of traumas. Now, this is a very important new paper. The military has been faced with huge numbers of soldiers coming back with what seems like mild, very, very mild concussions, and basically enormous effects in terms of their level of functioning and the level of really traumatization that the soldiers experience. And so the military is studying this very, very carefully, trying to tackle the situation. This is one of several studies that are coming out or have been coming out for the last few years, and there will be more, that show that soldiers with chronic daily headache have a lot more PTSD than soldiers with the occasional headache. But what's really important here is that to explain the level of chronic daily headaches, which is what many soldiers compare when they have these minor blast injuries, is that they have prior PTSD or concurrent PTSD. So trauma is somewhere in the mix, and it needs to be, in my opinion, be addressed. This is the conclusion. They say it much nicer than I just tried to say. A prevalence of chronic daily headache is high compared to the average general population, and the modulator of these severe headaches is PTSD. Now, going back to panic, flip-flopping back and forth a little bit, when you study panic disorder, you will realize that in many cases, the onset of panic has something to do with, again, stress, trauma, and more specifically with loss. While that's very difficult to study for obvious reasons, it's been in the literature for quite some time, and it bears some attention. This is one of the few studies that show that when people start having panic attacks, something usually bad happened to them in the year before compared to those who don't have panic disorder. And we'll see that's also true in chronic daily headaches. This is from one of my panic slides. Panic is very comorbid, as we already know, with chest pain, various types of other somatic pain. And some psychiatrists have termed the fact that people can have a lot of distress, and a lot of that distress being somatic physical pain, but they're not anxious. They have called that non-anxious panic. It's worth looking at that literature. It's very important for neuropsychiatry, certainly for neurologists dealing with chronic pain. Now, this is out of Richard Lipton's group, and it kind of shows, without going into all the details here, kind of shows a similar picture compared to the one we just saw about panic disorder, except that people who are somewhat older, age 40 and above, have a higher risk of developing chronic daily headaches, presumably because they accumulate more traumatic events over their lifetime. But there's clearly a correlation between the risk of developing chronic daily headaches and traumatic events. This has been certainly picked up in the literature and in the popular neurology press, and it really poses both patients and treaters a problem because a lot of people simply don't get the help they need. This is just a brief remark on various political considerations in splitting neurology and psychiatry, which of course happened only about 40-50 years ago. We're not going to go further, at least not during this brief presentation. Okay, just to really briefly point out to you that pain can happen in various places in the body, and not many people with migraines don't just have migraines, they just go to the neurologist because they have migraines, but they may go to a gastroenterologist or a rheumatologist for various other types of pain. This is another old quote from Freud, who knew that already. As a reminder, people with various types of pain, again, have the same kind of comorbidity, including depression and anxiety disorders, and it can be for people, it applies to people who have pain at the other extremity of the trunk. Okay, so what's the message here? This is a pompous way of saying that people matter in other people's lives, and they matter more to developing minds and brains, and they probably matter more to people who are suffering from various types of illness. And this is just one title of a number of articles that discuss what I was trying to convey, that many people with headaches have early traumatization and sometimes ongoing traumatization of various types. And I think that needs to be taken into account when we talk about comorbidity of psychiatric disorders and head pain. This is a very important study that I've shown for quite some few years now, that is longitudinal. Basically, people were studied, this is a British study, people were studied when they were really little, and then 20, 30 years later. And what comes out here is that separation events are specifically related to the development of headaches when people were in their 30s. Separation events, mostly parental separation and divorce, which unfortunately is very common, and it's clearly related to developing not just psychiatric disease like depression, but also various types of pain and unexplained medical conditions, so-called unexplained medical conditions. And certainly headache is one of the illnesses, or one of the syndromes that someone is at risk for when with that sort of history in the antecedents. This is our own study that was based on the previous slide. We were really looking at panic attacks and how to reproduce them experimentally, but what we also found is that people who, these are regular Columbia students, they don't have headaches and they don't have panic disorder, and about 50% of them had a history of parental divorce, and one or two unfortunately had a history of parental death. Their reaction to a temporary suppression of the endogenous opioid system, and we can talk about that, the details of that probably some other time, were completely different from those who didn't have those antecedents 20, 30 years prior. So this is certainly something to take into account. This is a more psychological slide. It addresses something called Alexithymia, which means that people who have been traumatized very early on in life sometimes are unable to say that they're suffering, that they are depressed, anxious, and such, and they express it in some other ways. And sometimes that's a somatic physical pain. And depending on where the pain is, they go to various specialists and get various levels of help. Real quick, this is just a reminder that many people flee conventional medicine, including neurology, and a lot of them, for various reasons, go into complementary alternative medicine, and I think there are good reasons for that. So this is one of my favorites. We look at part of the elephant, but we never look at the elephant, which has depression, anxiety, migraine, sleep disorders, epilepsy perhaps, and various other types of dysfunction, including pain, all in one. And it would behoove us as treaters to look at the whole beast and not just at one part of it. Real quick, there are implications for healthcare. I want to show you one slide from China where neurology consultations are between 1 and 3 minutes long, and it looks a little bit like this. I don't think you can provide quality care in any specialty, certainly not in people who are in acute pain or suffer from chronic pain in this kind of setting. Okay, eclectic, integrative, biological, psychological, mind-body approaches are needed. Drug therapy often not enough or even counterproductive because of dependence and adverse reactions that are more likely in those who have multiple symptoms and multiple types of pain. Informed consent issues are there. Is really that one drug the only way of treating it? Are there other ways, including non-drug ways, including psychotherapy of various types, that might be helpful? And then, of course, trauma prevention would be a good idea as well. Okay, I think that's pretty much it for this programmatic speech. And again, a lot of the references are on my website, and the slides are posted on the National Headache Foundation website as well.
Thank you, Dr. Preter.
Okay.
Our first question is, have you found that chronic daily headaches are a cause of suicidal behavior in your research? And this question comes from Linda.
Well, yeah, Linda, thanks very much for the question. We know that there are various types of headaches, and I think the one that has been mostly correlated with suicidal ideation and on occasion, unfortunately, suicidal acts has been cluster headache. I think the most profoundly depressed patients are those with cluster, and it is well known that they're probably at the highest risk of committing suicide, and probably followed by people with trigeminal neuralgia. So is that all related to the intensity of the pain? Yes, probably, but people who have certain types of prior experiences that put them at risk for experiencing pain as unbearable, isolating, are probably also at high risk for thinking about ending it all. And people have to be, family members, doctors, and so on, have to be well aware of the possible risk.
Thank you. Our next question comes from Janice. What are the implications for treatment since a doctor cannot technically go back in time and prevent a loved one from passing away?
Yeah, very, very important point. There's nothing we can do, unfortunately, there's nothing we can do about the past. To transform the past or the meaning of that event into something that is not exactly a picnic, but that is something that makes more sense to the person who survives and is traumatized by the loss, takes time. It cannot be achieved with one modality, and certainly cannot be achieved with drugs only, but it's possible. It requires a lot of work, and I think it's as best as we can do, since, as you said, there's nothing we can do about what happened.
Our next question comes from our Facebook page. If a psychiatrist is currently treating a client and is wondering about comorbidity of cluster headaches in clients who exhibit ideas of reference and ideas of delusion, the client exhibits these behaviors and he is wondering if they are driven by the compromising effects of the headaches.
Very good question. As we said earlier, I'm not aware of cluster headache directly causing ideas of reference. What is possible is that people who have undertreated or untreated brutally intensive pain of the cluster type are so agitated that they, somehow look psychotic or perhaps become psychotic, and a lot of them are so profoundly depressed that in the context of someone who might be predisposed to developing a psychotic depression, that's really what we're looking at. So is your patient suffering from a psychotic depression in the context of severe head pain? I would wonder. And then I would certainly also wonder about medication side effects and such that may contribute to what may look like psychosis in some. Certainly steroid treatments come to mind in that context.
Have you found headaches to be related to personality disorders such as borderline or avoidant personality disorders?
In my clinical work anyway, I think it's always good to stay away from being overly confident about those labels. What we know not all that much about so-called personality disorders, but what we know about personality disorders is that very commonly people who suffer from certain types of character patterns have very often a history of, well, early traumatization. So I would look there first before pinning a label to someone. It's also, in the context of our health insurance or absence of health insurance system, it's relevant that we stay with treatable conditions, because the moment someone is labeled as a personality disorder, it's very hard to get that label off again, and treatment is really limited. So I try to stay away from those. But does early traumatization cause characterologic consequences? Yeah, of course. And they all depend on the individual and various other types of influences, including current influences.
Thank you. Our next question comes from Sarah. Is there any medication that treats both depression and headache?
Well, since we're talking about medication, I've been around I was a resident in the 90s, and I still think that nortriptyline is a very decent drug for headaches. Perhaps the brand better than the generic, and they can certainly treat more than one symptom or more than one disorder. So tricyclics certainly are useful in the context of some sorts of some headaches. Now, the other very useful medication when we think about cluster, I think is totally underused, and that's of course lithium, which is a wonderful anti-suicide and antidepressant treatment that also treats cluster headaches and probably some other headaches as well. So that's certainly a wonderful piece in our rather limited armamentarium.
Our next question comes from Colleen. If one treats the underlying depression, is it possible that headaches can improve and vice versa?
Oh, absolutely. I think we have to be pragmatic. We often don't know what comes first, and it doesn't really matter all that much because both are cause serious impairment. So of course we treat them as much as we can at the same time with everything that the patient is in agreement with, and that everyone thinks is safe enough. These are not disorders that can be taken lightly. They cause a lot of morbidity and a lot of human suffering, and by all means in clinical practice we do everything we can to treat, and we have to address those together.
Our next question comes from Barbara. Can panic patients with migraine benefit from venlafaxine?
Well, venlafaxine has certainly a place in the armamentarium if it's used carefully, and if everyone is on board and understands that if it doesn't work, it's going to be a little hard to get off of it because of the withdrawal syndrome that many people, but not all people, have. Absolutely. So, it all depends on the individual diagnosis and the individual patient's constellation. If someone wants, perhaps like yourself, wants to try that medication, it's always, people with panic disorder need very little medication. They do much better with very, very low doses of these serotonergics or tricyclic drugs. They get very agitated sometimes and very jittery on more. So we have to distinguish between standard antidepressant dosages of those drugs and the kind of dosages required for people who are suffering from panic disorder. Panic disorder patients without serious depression need microscopic amounts of these medications to the tune of a milligram or two of Prozac and equivalent medications. So venlafaxine is quite stimulating and activating, so the dosages are much, much lower than what you would start someone with only depression on. That's certainly important to remember.
All right. Well, if we don't have any more questions being submitted, I'd like to thank you, Dr. Preter, for joining us this evening. We really enjoyed your presentation and hope that you would join us again.
Absolutely. Anytime you ask. I was very pleased. I hope it was useful.
All right. I'd like to thank everyone for joining us this evening. And please join us for our anxiety and headache chat, which will be December 4th. Have a great evening.
Thanks, everyone. Great evening. Bye-bye.